if we do get people dropping off or in or whatever, then we can show them the didactic and everything.
And then I'm assuming you guys can just see what's ever on my screen.
We can't yet, but whenever if you see that little green box at the bottom of the Zoom screen,
yes,
share. If you click that,
okay,
you pull up your PowerPoint as long as it's open.
Yep.
You'll be able to control it and
perfect. Okay.
But we'll go ahead. We can get started in a minute just for sake of time and everything.
Sure.
Yeah,
it's okay.
And my email won't pull off this.
No, I mean, it's not good. Right. It's okay.
Dr. Cibot, how many nurses are normally, like other providers? Is it just the 3 providers?
Yeah. And then
are they all physicians? Or?
No, there's 1 physician and 2 medics.
Okay, cool.
2 nurse practitioners and 1 pharmacist is empty.
Okay, I was just wondering.
Yeah. I was trying to think, is he here? He's empty.
Travis
Handbarger.
Yeah, I was about to say Hardbarger.
Yeah, and he's graduated from Marshall. So.
Cool.
Oh, cool.
Great. That's what I thought. I think I've emailed with him a couple of times. So
yeah.
Good.
Awesome. He's here.
Great.
Yeah. This is Tina's office, and then the new one, but she hasn't started.
Okay.
Officially.
Yeah, that'll be great.
And I'll have to give you her name and stuff so we can get her on the email.
Yeah.
Her name is Jennifer Akers.
Okay, cool.
So
That'll be perfect.
Get you her stuff.
Yeah.
Great.
All right, guys, we're going to go ahead and get started. We'll start with introductions real quick. Just let us know if you don't have a mic, you can chat it to us. But let's start. So Brian, I don't know if you can talk, but you introduced yourself. We have a couple more people on the line. That's okay. All right, and so then Calvin.
Yes, Calvin's my student on rotation, and then I believe it's also probably Gabrielle or Gabby, one of the pharmacy residents here.
Okay, perfect. Awesome. All right, and then Cody, you want to introduce yourself?
Sure. So Brian, you know me, we've met before. Gabby, Calvin, you're currently my students, but to the other office, my name is Cody, and I am a cardiology pharmacist. Right now what I do is work for Dr. Soto's, Cacno, and Bianco, and I specialize in advanced heart failure as well as pulmonary hypertension.
Awesome. So I'm Caitlin Ettinger. I'm the West Virginia Project ECHO coordinator. I'm actually here at the Craig, Virginia site. I'll just let everybody introduce themselves because we're joining remotely for a change.
Okay.
Traveled from Monroe Health Center in Union.
Dr. Hans Barger, Craig County.
Perfect.
Jay Mason, Project ECHO manager.
Awesome. All right, Cody, I'm going to let you share your screen and we'll go ahead and get started.
Thank you.
Yeah.
Do we want to close this?
We can put ourselves on mute.
Oh, is there no?
Let me start that over at the beginning. All right. As I already introduced myself, I'm going to dive right into what we'll be talking about today. I want to focus on type 2 diabetes and cardiovascular outcomes, specifically with our second-line agents. I have nothing to disclose for this presentation. As far as objectives and what I really want you to take away from today's presentation is kind of understanding why this is a big issue specifically for our state of West Virginia. So we're going to review the epidemiology and risk factors. Then we're going to discuss cardiovascular trials, in particular something called cibots. And then we're going to analyze the current literature out there to identify agents that we should be utilizing, and then how we can use those in our current practice. So when we talk about diabetes, it's always a good place to kind of understand why this is impactful. So for us, we have 84 million Americans every year that are either at risk of diabetes, so known as pre-diabetic. Approximately 90% of those patients do not know it. So that leads to every 21 seconds, one person being diagnosed with diabetes in the United States. Ultimately, that's 1 in 11 patients, or 1 in 11 Americans. If we visualize this with a map of the United States, we can see different shades of blue that I have represented here. The 2 darker shades of blue are 37 states out of 50 states. That means 8% of patients, roughly, within 2015 were being diagnosed with diabetes. If we focus in on the dark blue, we can see a pattern here. All these states are confined, typically in the southern region, and typically are known for having the unhealthier food trends, whether it be deep fried or whether it be sweet barbecue. What I did want to point out is that there is something known as a diabetes belt, and this is demonstrated by the red circle that we have here. It kind of shows that all these patients are clustered together. And as you probably noticed, we do have West Virginia located within this region. So within West Virginia itself, there's 15.3% of our patient population that has diabetes. Of that, we have about 48,000 patients that don't know it. And in addition, we have roughly 500,000 patients, or 36% of what patients we do have in West Virginia, being at a risk for a prediabetes state. The reason we care about this is because diabetes is associated with our complications. So we know stroke, blindness, kidney disease, heart disease, and neuropathy, as well as even amputations. So today we're going to focus predominantly on the heart disease component. So when we talk about diabetes and heart disease, we have a 2 to 3 times risk of an increase for heart disease if your patient is diabetic. That leads to 2,800 heart attacks annually per year. Of those patients, we have 30% of them being stented, and ultimately a 2 to 4 times risk higher of having a mortality or morbidity outcome. And ultimately, when we talk about the mortality aspect, 60% chance dying from heart disease. Looking specifically at West Virginia data, we can see that West Virginia, or heart disease, is the #1 leading cause of death within West Virginia, and it is higher than the national average when we look at it. So how do we treat this? How do we manage this? Where do we go? When we look at the 2017 glycemic management guidelines produced by the ADA, it's a very different approach. It's very based upon what the patient would need. So you're looking at more factors such as efficacy, weight gain, side effects, and cost. Now, in 2018, as far as the dual management or dual therapy, it changes play on how we do it. We're actually looking more at the ASCVD risk score to see if a patient, to see what agent the patient should be on as their primary agent. So as we know, when do we start dual therapy? It's important to note that we're not going to start that on every patient that walks in the hospital. We're going to target patients that have an A1C of greater than 9, and it's also going to be after we already implemented a lifestyle change, providing that education component for them, and then also our baseline therapy of metformin. So where do we go to next? We know that we have tons of different agents out there. How do we choose? We have sponurias, TZDs, we even have DPP4s, we have SGLT2s, we have our GLP1s, and we even have insulin as second-line options. So today we're going to focus on the newer agents that can be used. So going back to what therapy do we use and when? So what do the guidelines say? Well, the guidelines came out and they say that we have some really good options. Empagliflozin and liraglutide are the 2 options that they pull out specifically. And they say we can even consider canagliflozin as another line option. So how would you break this down and how to think about it in your practice is, first thing, does the patient have ASCVD risk? If they do, you should stop at that point and automatically only have 3 drugs in your brain: empagliflozin, liraglutide, or canagliflozin. If they don't, that's when you kind of go back to the management of the 2017 guidelines, where you're thinking more about patient-specific factors and drug risk and cost and things of that nature. So why does the ADA recommend only those 3 agents, empagliflozin, canagliflozin, and liraglutide? What makes them so great? So we're going to dive through the literature now to kind of pull out why these agents, and if there's any other front runners that we should be considering. Before we do that, it's important to understand why all these cibot trials or cardiology trials are coming about. So in 2008, the FDA mandated that all drug studies coming forward for any cardiovascular or also for any diabetic medication had to have something called a cibot trial, and it assesses for major adverse cardiovascular events, in which we look at either a 3 MACE primary endpoint or 4 MACE. So if we're looking at our 3-point, we have cardiovascular deaths, MI, or stroke. If we look at a 4-point, we are taking the 3-point and adding either hospitalization on from ACS, urgent revascularization processes, or other endpoints such as hospitalizations from heart failure, which is very common for most of the studies. So when we look at cibot trials, and we know that in 2008, this is when that mandate came out, we can see by this chart that there's a large trend upwards, and we can predict that there's going to dramatically be a lot more. So when we look at a timeline of all these trials, we can see, yeah, they kind of start popping up in 2013, but we have tons even planned for in the future. So right now, we're sitting at a pretty good point with a lot of data coming out. So when we look at our first class of agents that we're going to talk about, sulfonylureas, we're very familiar with our second generation, which is glyburide or glipizide, sorry, or glimepiride, our third generation. When we talk about patient-specific factors that we should consider, we always have to take into consideration hypoglycemia, which is a moderate risk, efficacy, which it has pretty high efficacy of an A1C lowering of 1.25%. It is associated with a weight gain, which is not typically a good benefit or a positive side effect of this medication. And then typical side effects for hypoglycemic agents is the hypoglycemia. We look at a timeline for sulfonylureas and when they came out on market and how we should interpret them. Pretty controversial for sulfonylureas. So they were one of the agents that have been around for the longest, in 1937 being the first time. And then we have our first generation, 1950s, that are marketed. And we see about a 20-year span of before we actually see any reports of cardiovascular events being made. And at that point, we see more of our studies coming forward, Cochrane reviews and meta-analysis, in which we see a little bit of a mixed review. We see some sulfonylurea meta-analysis coming forward saying that there is no risk of CV events, and that we have some coming forward saying there is, specifically with the first generation. So it's just something to keep in mind that we really don't have a clear picture when we talk about sulfonylureas, whether they're beneficial for our patients with any sort of heart condition. When we talk about our TZDs, we have a lot more literature. So these are the ones that have kind of been very controversial for heart failure in particular. We have pioglitazone, which is our Actos. We have our rosiglitazone, which is our Avandia. As far as efficacy, it's pretty high efficacy. So it is a favored drug because it's a good dual agent for lowering someone quite a few points on the A1C scale. Hypoglycemic risk is pretty low. They are associated with weight gain. And then as we talked about side effects, heart failure is the big one that sticks out there, as well as some of them are noted to also increase our LDL cholesterol. So we do have to be mindful and careful with that. So thinking about our timeline for TZDs, I know many of you probably are familiar with this, but they were released in 1996 into the US market. And shortly after that, we have rosiglitazone and pioglitazone come on market. And this is kind of where it gets interesting, because when rosiglitazone was released on market, we have an interim analysis that was published a few years later of the RECORD, which is its main study. And this is when the FDA comes out and says rosiglitazone can cause or may exacerbate heart failure. Then we have a few published papers, such as New England Journal of Medicine, some meta-analysis that come out, and they confirm the fact that we need to be aware of reduced our heart failure risks in these patients. So pulling out the primary literature, which I think is the most important thing to do for this drug class, we have RECORD as one of our first studies that comes available, and that's for rosiglitazone. What we get from this study is that there's no reduction in CV hospitalization or mortality, but we do have a very significant increase for risk of heart failure with rosiglitazone. When we talk about proactive, which is pioglitazone, we do have some benefit that emerges. We see that there's a significant reduction in the composite endpoint for the mortality, and that we have no reduction in the macrovascular endpoints, but we also have that increased risk of heart failure that develops in this. In IRIS, also looking at pioglitazone, we see that there is a benefit with a decreased risk of stroke. But if we were to take a general overall view of these from RECORD, we're knocking it out. We don't want to do rosiglitazone in our patients with any sort of cardiovascular risk. Proactive, we can kind of balance it depending on what they have. If they have a pre-existing condition of heart failure, you wouldn't want to use it. But if it's just a CAD patient, you can kind of maybe benefit from it, as we know that it does have a reduction in the composite endpoint of mortality. And then when we look at pioglitazone even further, specifically if you have a patient with CAD and has had a recent stroke or is at high risk for a stroke, you might want to push them forward towards the pioglitazone because we do see benefit in that patient population. But again, avoiding all over our patients with heart failure. When we talk about our DPP4 inhibitors, this is relatively a newer class of medication. The way to identify all these medications are they are the ones that end with the term gliptin. So we have our saxagliptin, our alogliptin, litagliptin, and sitagliptin as well. Efficacy is pretty intermediate as far as how much they lower the A1C, about 0.75. They do have a lower risk of causing hypoglycemia, which is a benefit specifically for some of our older patients, and they are not associated with that nasty weight gain. As far as side effects, the ones that are marked labeled pretty acutely are going to be our acute pancreatitis and then also joint pain for our patients. I just want to put this in there as far as a mechanism for completion, but how they ultimately work for our patients, because they are a newer class of medications and something that might not be known, is they are going to regulate blood glucose levels by increasing insulin release and ultimately decreasing glucagon secretion. So if we look at the timeline for when DPP4 inhibitors released to market, sitagliptin was our first one in combination with metformin, followed by saxagliptin and litagliptin. And as you can see, we have our landmark trials emerge. And what do the landmark trials tell us about this drug class? So if we look at our first one, Save Your Tummy, this is what we look at for our saxagliptin. It is a 3-part MACE endpoint in which we see that there's no clinical significance that we can take away from this. As far as our exam for alogliptin, also the 3-part MACE endpoint, we again see that there is no clinical significance. And the same thing for sitagliptin, we also see that there's no clinical significance. But what if we break down these massive composite endpoints? Well, if we do that, we can see some significance. Unfortunately, with saxagliptin, we actually see a significance towards an increase of hospitalization for our heart failure patients. So taking that away, what they did is they looked at the other agents to see if there was an increase. So from a post hoc analysis of Examine, they see an increased trend towards hospitalization, specifically for patients that already have heart failure. So this released an FDA statement shortly after that, saying that saxagliptin and litagliptin may increase the risk of heart failure overall and probably should not be used in those patients, specifically if they already have heart failure underlying or some sort of heart condition, as well as CKD. So if you were to choose a DPP4 inhibitor for our patients that have cardiovascular risk, if they have heart failure, you're going to want to go with sitagliptin. So moving on to one of the newer drug classes that has a lot more literature coming out right now, are SGLT2s. We have dapagliflozin, canagliflozin, and empagliflozin. For efficacy, we have an intermediate efficacy, generally around 0.5 to 0.8 A1C lowering. Low risk of hypoglycemia, which is preferred for our patients. And again, associated with weight loss, which is beneficial for a lot of our patients. And then side effects, which are pretty profound with canagliflozin, are going to be our amputation risk, and then our high risk of DKA, as well as general urinary tract infections. And they sometimes are associated with a higher increased risk of our LDL cholesterol. Since it is a newer drug class, I just kind of want to bring up the mechanism of overall how it does work. So it works predominantly on the proximal tubule, and what it does is it prevents the reabsorption of our glucose, ultimately making the patient pee out the glucose as much as possible. So how does this translate into heart failure? Why is this drug class coming forward as potentially being very beneficial for our heart failure patients? Well, what it does, working through a hormonal pathway, is it decreases the outflow to the heart overall, and decreases the volume load as well as the wall stress. So if you look at a timeline for SGLT2s and when they came on the market and when our landmark trials really come forward, it's relatively recent, as I've kind of been pointing out. So we have canagliflozin as being our first one, followed by empagliflozin and dapagliflozin in 2014. It's in 2015 where we see the FDA kind of get involved when we come back looking at some of the studies, because we have an increased risk of infection and UTIs and bone fractures, and this is just due to the mechanism of action. So looking at our landmark trials and kind of what to take away from these, when we look at EMPA-RAG, which is for empagliflozin, it is a 3-part MACE endpoint, so CVDS, the MI, and the stroke. What we take away from this is that this agent was found to be superior versus placebo. For canagliflozin and Canvas, we also have that 3-part primary MACE endpoint, in which we find that it is also superior with a P of 0.02. Now, when we look at Declare TIMI 58, which is dapagliflozin's landmark trial with a 3-part MACE endpoint, we see that it's not significant. If we break down all these composite endpoints and we look at them individually, can we see any significance for any of these agents and what's driving our primary endpoints? So when we look at empagliflozin, it's predominantly driven by our cardiovascular death and then also hospital readmission rates for heart failure. Canagliflozin, all the way down the board, we don't see any significance driving it forward as far as individual endpoints. But when we look at dapagliflozin, we do see, if we just take our cardiovascular death and hospitalization, we do see some clinical benefit, and it has a significant p-value overall. So we look at our glucagon-like peptide, or GLP1 receptors. These are the ones that are going to end with anything tied, and they're injectable formulations. So they do have a really high efficacy for our patients, A1C of lowering any between 0.5 to 1.1%. Hypoglycemic risk is relatively low. They are associated with weight loss, which is a good thing. As far as our side effects, GI side effects tend to be the biggest one, as well as some injection site reactions. As far as mechanism, I just want to bring this forward because it is one of the newer agents or newer drug classes out on the market. But overall, what we're doing is increasing the insulin secretion to ultimately decrease glucagon secretion. So how does this work in part with the heart failure? So what GLP-1s do is they'll actually increase our myocardial contraction. And when we look at our timeline of GLP-1s and how these come to play, we also have to consider when they were approved and how they came out on the market. So if you look at lexasenatide, or Alexa is the landmark trial, we have a 4-point MACE endpoint, CV death, MI, stroke, or unstable angina. It's here that we don't have any clinical significance for lexasenatide. When we look at LEADER, we do have clinical significance coming forward for our liraglutide agent, and we only have a 3-part MACE endpoint. As far as SUSTAIN, looking at semaglutide, we do have a clinical significant endpoint as well. Again, breaking down those composite endpoints to see what's really driving us forward, we do see that liraglutide is driven forward predominantly by the cardiovascular death arm, myocardial infarction. And then when we look at semaglutide, we see that it's driven forward by the stroke component. So I know I just threw a lot of literature at you. I think it's kind of important that I wrap that up and summarize that as far as where the FDA standpoint is, where the literature standpoint is, and what to take away if we have a patient with CAD coming in, what to take away if a patient has heart failure. So when we talk about our sulfonylureas, we pretty much have a neutral benefit as far as our CAD patients and as far as our heart failure patients. The literature is pretty controversial. And as far as the FDA standpoint, they do note an increased risk of mortality. For our TZDs, there's potential benefit for our CAD patients with pioglitazone, but an increased risk of having heart failure out there. Literature supports the fact of heart failure being one of our main concerns, and the FDA stands behind that and ultimately put a black box warning on our pioglitazone and rosiglitazone. For our DPP4 inhibitors, we have a neutral standpoint for our CAD patients, but for our heart failure patients, we note that there is increased risk of saxagliptin and alogliptin for heart failure causation. This is supported by literature and ultimately also supported by the FDA, in which they came out with an increased risk for heart failure with those 2 agents. When we talk about our SGLT2s, this is the one drug class that we actually have benefit in both the CAD patients and then also our heart failure patients. And this is supported both by the FDA and literature standpoint. When we look at our GLP-1s, they have a neutral benefit as far as the CAD, with the exception of liraglutide, which is beneficial, and a neutral benefit for our heart failure patients, recommended and supported by literature in both the FDA. And just for completion's sake, I did add insulin in there, in which we have supportive recommendations for neutral on both those heart failure and the CAD patients. So what are some other additional considerations that we have to take into consideration before we pick which agent we want to do? So cost, route of administration, patient preferences, and other comorbidities also need to be considered. When we look at cost of these agents, our older agents are going to be the more affordable ones, sulfonylureas, sometimes it's the TZDs as well. What a lot of companies have out there, especially for the newer agents, are coupon cards. And they are very easy to get a hold of. You can print them out online for your patients. And it's something to consider, especially for some of the newer agents that are coming out, if we want to make them affordable for our patients. And I will say, working with West Virginia Medicaid, they are easier to get approved than most other insurances. So it's just something to consider. As long as the patient is titrated up on other managements, such as metformin, they have to be on max tolerated dose before they will approve one of the newer agents, the GLP1 or the SGLT2s. Route of administration is also something important to consider. For subcutaneous, such as our GLP1s, what is our patient's hygiene? Do they have the capability of making sure that they can inject that site cleanly? And then also frequency. Are they a patient that is not very compliant, in which we can use a extended release exenatide once weekly? Something just to consider. As far as oral therapies, we have the same thing. Frequency, is our patient compliant? If not, we might want to favor something that's once daily versus twice daily. We also have to consider what a patient sees. So social media is going to be a big player, especially when it comes forward with some of the newer agents on market. There's a lot of commercials out there as far as you too can be affected by this. You can get money back from this lawsuit. Just being cognizant of what's available as far as commercials and what patients are seeing, because those are going to be the concerns that they see and bring forward to you. Also, for comorbidities, one of the biggest players in this is going to be renal function. So in particular, looking at CKD patients and where we see our benefits with these agents is the benefits actually seen with liraglutide as our GLP-1, and then also our SGLT2 inhibitor, both canagliflozin and empagliflozin. And if we were to give a patient one of these agents, it's just important to note that we do have to take into consideration how we're going to renally dose adjust these. And I will say some medications are dosed differently, some off of creatinine clearance and some off of estimated GFR. So it's important to look at the package labeling inserts. So where does that leave us? Well, that leaves us going back to the future, in which we have multiple other studies coming out in which we can take away more information and hopefully build a better picture of how to treat our patients with our cardiovascular risk, in particular heart failure. So at this time, I'm welcoming any questions or anything that you'd like to ask.
Hello.
Hi.
Yeah, specifically with the SGLT inhibitor and that GLP1 agonist. Okay, I'm trying to get my patient on that, citing weight loss and cardiac benefit. I mean, from my perspective, the insurance are not accepting that. I don't know whether I'm communicating them in a wrong way or they are just not going to accept it. Anybody had any different experience or different way to complete the prior auth so that they get approved?
Yeah, absolutely. So I can speak to this a little bit. I do a lot of prior authorizations for these patients in our clinic. So something that I found is they have to be on the max tolerated dose of metformin prior to doing it. And then I additionally usually send whatever primary literature I'm going to send as well. So I'll find the landmark trial. If I'm doing GLP-1 for liraglutide, I'll send that as well as the SGLT2. And generally, I get them approved if I do a peer-to-peer conversation.
So do you send the whole study or the abstract?
Yes.
Study?
I'll send the whole study. I'll just fax them all over. Sometimes they get 20-some pages from me, but I want everything to be complete so they can't kind of challenge it.
Okay.
Hey, Cody, thank you so much. That was awesome. Trisha, I don't know if you're trying to talk. I think you're muted. Let me unmute you real quick. There we go.
going into it.
Hey, Trisha, I'm sorry. I don't think we can hear you. Do you know if your mic is working?
And the specialists.
I'm sorry.
Specialists, but they kind of.
Yeah.
Once again, I think there's a disconnect.
Sorry.
Hoping at WVU and more.
We'll make sure if you can hear us, we'll make sure that or Cody, can you hear her?
Oh. Sorry, I can't hear her. I can hear you.
Okay. Okay, so Trisha, I'll make sure to get the, if you want to chat the question to us, that would be awesome.
I kept getting the email.
Do you mean heart failure in general or specifically diabetic medications? Because Rachel and I are always available within the clinic if you're looking for more of the pharmacy input of it. As far as providers, it's going to depend on who's down in clinic. But yeah, we're more than welcome to kind of filter some questions for you and come up with some recommendations. Yeah. So clinic would be the best person to kind of reach out to, and the providers fluctuate through there, as well as Rachel and I are down there if you need like medication aspects of everything. Do you guys need the number for our WVU clinic, specifically like our backlines? Okay. I will have to get you that. I can provide it, and I can have, would you guys Echo send it out for us? Okay, perfect. So I'll get that for you, and we'll send it out along with the PowerPoint today. That way you guys have that and kind of someone to reach out to.
That's awesome. Thank you, Cody. Yeah, I'll send anything that we need for the session. I was wondering too, just I don't know, behaviorally maybe, for medications, because you work with cardiac heart failure people. Do oral medicines work better if they're taking like a lot of things that they can take at the same time? I know that's more of like making them understand to take things together, but I was just wondering.
So a lot of it's very patient specific and what medications that we are adding together. So if it's a medication that needs better bioavailability, I kind of educate them on how to separate that out from their other medications, or whether they need to take it with food or not. But typically what I do for our patients here, just because our patient population seems to have low health literacy, is I choose oral agents because a lot of them don't have the knowledge, I guess, to make sure that it is a clean injection site and things of that nature. But I will go with orals as my first line. Particularly, I'll go with an SGLT2 because they are once daily dosing if I can get away with it.
Awesome. Thank you.
Of course.
Guys, yeah. Do you guys have any other questions? I know a couple people joined on, and I think I see Dale, and I know Dr. Pollywall. So I just want to make sure if you guys had any questions, we got it covered. Yeah, thank you, Trisha. No worries. All right, guys. So we'll talk to you later. Cody, again, thank you so much. That was awesome.
Thank you.
All right. Thank you. Bye.
That's just tell them it's cool.